Good afternoon. This is Greg Lois. I'm the managing partner of the Lois Law Firm. We defend employers and carriers in New Jersey and New York workers' compensation matters. In New York, virtually throughout almost the entire state, and in New Jersey in all workers' compensation courts. Today, our topic of conversation is medical treatment and non-acute pain management. We're going to talk about opiates, narcotics, and medical marijuana. Thanks for joining us today. There's been a lot of changes in New York workers' compensation world in regards to medical treatment. We're going to talk about some of the big stuff that's changed in the last couple months and some of the legal decisions that have come out just in the last couple weeks in regards to medical marijuana and pain management. Today, I'm going to talk about medical benefits in general. We're going to talk about variances and denials. I'm going to talk about some of the new stuff, and the new stuff is really what the board is planning on doing this year. We're going to change the medical fee schedule. We're going to change all of the medical records that you've been used to seeing, that C4 family of forms, and we're going to start to see medical marijuana and more in our cases. This is a totally live webinar today. Please feel free to ask me your questions. I can see them pop up on the monitor up there, and I can see them pop down here as well. So please feel free to ask me your questions. It makes it a lot more fun for me and a lot more useful for you as the audience. It also helps me to tailor how the future webinars, the kind of topics we cover. I'm going to try to get to as many questions as I can at the end of the webinar, but if I don't get to your question today, be certain that I'll email you or call you with a response. Okay, let's dive in. There's only 4 benefits available under the New York Workers' Compensation Law. And those benefits are medical treatment, lost time wage compensation, permanent disability benefits, and that could be permanent partial, scheduled loss of use or loss of wage earning capacity, and of course, death or dependency benefits. We've talked about medical benefits today. Then today I'm going to focus on the interesting stuff, the stuff that's changed. Last month, we talked about temporary disability benefits and wage compensation and calculating AWW and all the other interesting things we can. In November, we'll be talking about things like LWEC trials, scheduled loss of use, how to resolve or leverage disputes about permanent partial disability into good settlements. All right, so New York has medical treatment guidelines. These are largely copied and pasted from Colorado medical treatment guidelines. In the last few years, they added a non-acute pain management guideline. This presentation is not going to really go over the guidelines line by line and guideline by guideline. In fact, if you want to do that, and if you need a good introduction to the guidelines, my recommendation is always that you check out the very good training, which is available on the Workers' Compensation Board's website for that. There is training for each of the guidelines, and it walks you through the guidelines module by module. Each module takes about 20 to 45 minutes to tackle. They are tailored. There's different courses. There's some courses for judges and attorneys, some for examiners, and some for medical professionals. But I've encouraged all my teammates, my staff, my attorneys here to take these classes because they walk through the guidelines in a very simple way. I think there's good little quizzes built into it. At the end, you get your little certificate. So I really think that's the best way to learn about the guidelines. There's also a chapter in my New York Workers' Compensation Handbook about the guidelines and how they apply. But typically, the guidelines are really pretty easy to use. I think most of my clients either have it built into the UR system, or we just keep, like I do, I keep the PDFs of the guidelines up on my computer pretty much all the time, and I'm doing a Control F at all times, Command Find, for those questions or concerns I have about a specific treatment course that's being provided. The guidelines have not changed since the last time I gave this presentation, so let's focus on the stuff that has changed and is different. Fee schedule payments are all going to change. The board, we just exited the comment period for the new fee schedules, which entertainingly the board first said, hey, there's going to be new fee schedules. They said this back in June. It took them a while to actually promulgate or show everybody what the new fee schedules are going to be. We've had access to them. It appears that the average fee schedule change is about 5% in favor of the medical providers. The board has announced that it wants those fee schedules to go into effect as of October 1, 2018. So you'll see a new fee schedule at that time. So expect more information and more news about that as that date is firmed up and that fee schedule is actually issued. In regards to the guidelines, they are typically referred to by the physicians who often want to perform some kind of treatment that exceeds the guidelines or they know varies from the normal treatment course. At that time, the physician asks to either file a request for authorization, that would be a C-4 auth, or an MG-2, that's a variance request, saying essentially, I want to vary from the guidelines. We don't see changes in regards to the MG-2, but in regards to the C-4 auth, our guidance to clients in the past had been that if you are denying a request for authorization, you should also issue a C-8.1A, which is a form that essentially says to the doctor, hello, doctor, any treatment you're going to perform for this claimant in the future, I'm going to deny because I don't think it's medically necessary, right? So at the time you deny the C-4 authorization, in other words, the doctor saying, hello, I'd like to embark on this prospective course of curative care. Do you approve of it? We would fill out the C-4 auth. Usually it would be then designated a D, meaning denial, saying, no, we really don't think this treatment is going to benefit the claimant or patient. Or it would say we'll authorize half of it or not all of it or something like that. And then we would also instruct clients to file the C-8.1A saying, dear doctor, no more treatment for this patient is going to be paid for by us. The board has now issued guidance, and the guidance was just issued a couple of weeks ago on July 25th, saying the C-8.1A is no longer necessary because it's redundant. I got to admit, I was a little shocked by this. That was probably one of the first times the board ever admitted that one of the things it's been requiring us to do for years has been redundant. But going forward, we are instructing our clients we no longer have to fill that out. I like to touch on the issue of out-of-state treatment in New York in particular, where there is a fee schedule and where physicians typically have offices, or not typically, but often have offices outside the city. I mean, it's very common for a physician to have an office in New York City, but treat patients in New Jersey as well, and maybe even have admitting privileges to a New Jersey facility. Or in the case of many of our New York physicians, they're partners in a special surgery center that just performs arthroscopic knee or elbow or shoulder cases outside of the city. And there have been a rash of cases in which the claimant was treating in New York and then crossed the river to go get treatment in New Jersey. At that time, the physician says, the guidelines do not apply, and I'm now going to bill you under New Jersey's usual and customary, which far exceeds the fee schedule. In fact, will often be multiples of what would be allowed for the same treatment under the fee schedule. In those circumstances, first, we do defend and defend with a very high degree of success those medical provider claims that are filed under the New Jersey statute and filed under the New Jersey Workers' Compensation Act, seeking payment for workers' compensation treatment rendered in New Jersey, but for an accident arising under the New York workers' compensation law. I can also tell you that in regards to the medical treatment guidelines, there is now guidance, there's case law that says that the out-of-state physician should follow the medical treatment guidelines in New York where possible. Again, those guidelines are considered to be best practice or standard of care. And so for the physician to simply in another state say, I'm not doing that, or I'm doing whatever I want, the board will take into consideration, of course, that maybe they're not going to file the New York State forms, but they are going to be expected to largely hew to the New York treatment guidelines. So that's also very good for carriers and employers in terms of reducing cost. Okay, speaking about forms, the board loves forms, the board loves forms, the board loves forms. Well, they're going to be doing away with a lot of their own forms and replacing with a new one. The board will be doing away with the C-4 family of forms. They've announced that as of January 1, 2019, carriers should begin accepting these forms in lieu of the C-4 family of forms. And so that would be your your physician's initial report, the C-4, C-4.2, which is the follow-up narratives, the C-AMRs, where we would typically see radiological, diagnostic studies come in on those, and of course, psychologist reports, physical therapist reports, they're all going to be replaced by the CMS-1500. That goal is to begin on January 1, 2019. We don't expect this to be a hardship for the medical treatment providers who are already using these forms to communicate with Medicare. All right, well, I'd like to speak just a bit about maximum medical improvement in New York. One of our big challenges in New York is getting the patient or the claimant to maximum medical improvement. And the reason that's a barrier is because the claimant is often not motivated to return to work. They're often choosing physicians who they were referred to by their attorney, not by another physician. And the claimant is not interested in doing anything but continuing their care. And you see that often where the claimant is really stretching out medical treatment. Maybe they don't have a job to go back to. Maybe they were seasonal. Maybe they just don't want to go back to work, and they've got a physician who's continuing to find them less than able to work or not able to work in a partial capacity. And so often in New York, we have to litigate this issue of maximum medical improvement. In the past, this was very difficult, and I can tell you how frustrated I've been as a trial attorney trying to litigate the issue of maximum medical improvement, where often the treating physician, 3, 4, 5 years into the treatment of a claimant is still finding them totally disabled for things like a sprained ankle or for a arthroscopically repaired meniscal tear partial of a knee. Relatively minor conditions are deemed totally disabling for years and years and years. To my way of thinking, the physicians don't have a terrible, a lot of credibility with me, and they seem like they were just parroting the sort of subjective complaints of a claimant on and on and on. So we've got to litigate this issue of, has the claimant reached a medical plateau? Is there further curative care that they would benefit from? And we often come to cases in which the claimant has maybe said, or there was a mention that maybe surgery could be an option in the future. And so every time we go to litigate the case, all of a sudden the claimant says, well, I'm thinking about getting the surgery, judge. And the judge, who wants the claimant to get every bit of curative care possible, will say, well, let's adjourn this matter, continue this case, so the claimant can consider getting that surgery. Just want to remind the audience that there is case law out there, and there are statements from the board defining maximum medical improvement and saying it is not inconsistent with a future need for things, including surgeries. But if the claimant's refusing to undergo them now, and we often hear this from the claimant where they say, oh, I'm just scared of surgery, I just don't want to do it, blah, 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 that's not an excuse and not a barrier to a finding of maximum medical improvement. So that's something I like to bring up every time I talk about medical treatment in New York, and about getting aggressive on claimants who are sometimes using surgery as a dodge or a shield to get out of actually having to be found to have some work capacity. All right, let's talk about one of the biggest and hottest topics in New York workers' compensation, really workers' compensation across the country, and that's narcotics and opiates. New York does have non-acute pain management guidelines, which were intended to address this. Of course, we haven't seen the sort of traction we'd like to see with it, but there has been some good developments from the New York non-acute pain management guidelines. First, it divides up patients into 2 basic groups. The patient who are opiate naive, meaning patients who have not been on opiates, and then the patients who've been on it for a long period of time. For opiate naive, or in order to begin issuing opiates to a patient, the physician has to demonstrate that there has been a successful trial, and that successful trial includes things like functional improvement. And subjectively, the claimant telling you, you know what, this is making me better. And this flies in the face of what we typically see in the pain management context, where the claimant goes to pain management, says I'm 10 out of 10, and a year later, and 320 milligrams of Percocet a day later is still saying I'm 10 out of 10. Well, you haven't seen any benefit there, and certainly that's not helping you. So for the opiate naive, there has to be a demonstration of improvement in order for the opiate to continue. 2 weeks at a time, it should be prescribed, not more than that, which is also very good for us in terms of new opiate prescribees. But that's not really our problem population. Our problem population is really the claimants and patients who've been on it for years and years, and often for something quite subjective or inchoate, like unspecified low back pain or slipped disc or bulging herniation, but not really a heck of a lot there. For those patients, the board has been very reluctant to completely separate them from their narcotics. We have been successful in obtaining some approval from judges and direction that the claimant must attend weaning programs. They also are limited in regards to what they can be obtaining. They should be getting 1 short-acting and 1 long-acting pain management modality. There are certain modalities which are completely being eliminated, such as the subbucals, the injections, the inhaled. And of course, there is now a requirement for mandatory urine drug testing. Now, this is not on a specific schedule. If you look in the non-acute pain management guidelines, there is a chart which talks about the different types of narcotic chronicity there and how often they need to be evaluated for a urine drug test. I've had some clients tell me that, Greg, this is incredibly expensive. We're getting charged $1,500, $1,600, $1,800 a month for urine drug toxicology evaluations for their patients. I think that's a moment for you to either dispute that or talk to the pain management physician. There is no requirement for once a month evaluations. In fact, in there it says periodic and as necessary and should be based on other risk factors as well. However, we do think the drug testing should be done. Unfortunately, it cannot be shared directly with the carrier or the employer and cannot be used as grounds to terminate the employee. And this is really to encourage the employee's participation in the urine drug testing. So it's of limited use in terms of leverage on the claimant or towards pushing the case towards a resolution. But it is useful for the pain manager for them to evaluate whether this claimant is really properly utilizing their medications or not. Medical marijuana is not discussed anywhere in the medical treatment guidelines, regulations, etc. However, there are a number of cases in which medical marijuana has been approved by the board, often in challenge to a variance request, as an accepted modality for pain management. So here's how this happens. It is not part of the medical treatment guidelines for any body part injury or illness. However, New York does have a medical marijuana program. The program started out, as many of these programs have started out, as essentially end-of-life care for the terminally ill. And in fact, it was limited to those patients with less than 12 months to live who had Crohn's disease or very specific types of invasive and painful cancers. Over time, it's been expanded and is now expanded to include a host of other conditions, including musculoskeletal pain, which has not been remediated with other types of medications. The program is literally dispensing marijuana, which is often smoked by the patients. The program allows them to receive up to 2 ounces per month of marijuana. And again, they are instructed that they are to smoke it in their home. There are significant restrictions on this program, specifically telling the program participants they're not to be operating machinery, they shouldn't be driving under the influence. However, we know that marijuana intoxication is very difficult to detect, and in fact, the levels of marijuana intoxication are certainly not, there's no generally accepted level. So this is a challenge in regards to policing the intoxication or overuse. In the cases where this has been approved as a modality of treatment for claimants, the next problem that occurs is the carrier or employer cannot pay for medical marijuana. Remember, this is a federally scheduled banned substance, and in order for the employer to directly pay for it, they would be violating federal law. So this is a challenge. So what's happened is the case law has developed in New York, and this has been about a year now, where carriers or employers are being directed to use an M&T to directly reimburse the claimant for their medical marijuana. So that's interesting. You're not going to be issuing them a medication card that they're going to be able to present at a dispensary. Instead, the claimant will pay for this directly and then seek reimbursement on an M&T. All right, so I'm beginning to see at least one good question popping up here from Leonard. So let's look ahead as to what we're going to cover in the future. This year, I think we're all going to be looking at the implementation of the CMS-1500. Remember, your fee schedule rates are going to be changing soon. October 1, 2018 is our prediction. The long discussed medical portal is expected to go live at the end of this year. This is a medical portal that is intended for the use of adjusters and examiners. And when it works, or if it works, you'll be able to see requests for variances and authorizations pop up on a separate screen within eCase so that you can approve or disapprove treatments in an individual case. We also expect to see more case law and practical implications of medical marijuana as it becomes more pervasive in this state. I can tell you that we also practice this firm in New Jersey, and certainly in New Jersey, this is a big hot topic. Okay. Leonard asked a question. Can you discuss a strategy to seek permanency for knees when treatment calls for TKR, but the claimant refuses and thus extends an MMI finding? Great, so that's exactly addresses that topic that we kind of brought up in this presentation, which is that this is a long, oft used tactic by claimants. And this tactic is, well, I'm coming up to the MMI finding. There's really nothing left for me. And in this case, you're talking about a knee case where all that's left is a TKR, total knee replacement. It's been recommended I undergo this surgery. But instead, I say I'm not going to undergo the surgery. I'm scared of it, or judge, I can't do it. I've got young kids at home. I can't be out of work or be off my feet for 2 weeks or whatever the story is. And so the claimant refuses to get the surgery. So in those circumstances, I'm expecting you to get an IME from an evaluator who should say something like, this claimant's at maximum medical improvement unless they get the TKR, which they refuse to get. Done, end of story. The judge should take notice of the status of the case and find that maximum medical has been reached and the leg is susceptible to a scheduled loss of use finding. So that's how I would resolve that one. All right. I also see a question about the status of the new formulary. The comment period is over. Yeah, that's something that we can talk about as we see what else comes onto that formulary. I don't know if this question is specifically about medical marijuana, but it is not addressed in the formulary, and I do not expect it to be addressed on the formulary. Okay, that's all our questions from this week. Thanks for joining us. If you have any other questions that you'd like me to get to, please feel free to email me, text me, or call me. I'd be happy to answer any other questions you have about medical treatment. Next month, we're going to be talking about cases in which the burden of proof is on the claimant. So we're going to be talking about repetitive use injuries, occupational exposure injuries, and of course, the cardiac claims. Please join us for that. All right, hope your summer's going great, and I'll see you in September.